So, what are the complications of hypertension? Hypertension, if left untreated, uncontrolled, can lead to a lot of complications, damage the blood vessels, and various organs in the body can get affected. These are known as target organ damage or end organ damage seen with hypertension. It damages the blood vessels, vasculopathy occurs, it leads to endothelial hyperplasia, medial hypertrophy, segmental hyalinosis, and fibrinoid necrosis, and accelerates atherosclerosis. In the cardiovascular system in the heart, it can lead initially to hypertrophy of the left ventricle, and that would lead to diastolic heart failure, or what is now known as heart failure with preserved ejection fraction. It will lead to diastolic dysfunction. As the hypertension progresses, it would lead further to heart failure with reduced ejection fraction and congestive heart failure. Hypertension, as I have told you, is a very important risk factor for acute myocardial infarction, and it can lead to coronary artery disease, and also it can cause atrial fibrillation. One of the causes of atrial fibrillation is hypertension. In the brain, it can cause strokes, cerebrovascular episodes. Both hypertension and hemorrhagic strokes are, in fact, if you look at the risk factors for hemorrhagic stroke, the most important risk factor is hypertension. Ischemic strokes also can occur in patients who have hypertension. Lacunar infarcts, vascular dementia are other complications which can occur in the brain. Now, there is a condition called hypertensive encephalopathy, which can occur when the patient has very high accelerated or malignant hypertension, in which the patient has some altered consciousness, and that can lead to even focal neurological deficit, which actually reverses back to normal once the blood pressure returns to normal. Therefore, this condition, hypertensive encephalopathy, is a term which is used when patients have very severe, very high malignant hypertension. It can affect the eyes, blood vessels in the retina can get affected and can lead to retinopathy. I will describe this in my subsequent slides. And peripheral vascular disease, because of involvement of peripheral blood vessels, that can lead to a condition called peripheral vascular disease, in which patients complain of claudication, which is pain in the calf muscles after walking for a particular distance, because blood flow cannot increase to supply the exercising calf muscles, and therefore pain in the calf muscles which occurs with exertion is known as claudication or vascular claudication. And we can do what is known as ankle brachial pressure index, ABPI, where the ankle systolic blood pressure, which is divided by brachial systolic blood pressure by Doppler technique, and can be done, should be normally not about 1, but in patients who have peripheral artery disease, the ABPI is markedly decreased. Hypertension in the long run can lead to nephropathy. Initially, it can cause albuminuria, and we have to do what is known as the albumin creatinine, urinary albumin creatinine ratio, and subsequently it can lead to various stages of chronic kidney disease, stage 1, stage 2, stage 3, stage 4, stage 5, and ultimately would lead to end stage renal disease, and these patients may require hemodialysis or renal replacement therapy or renal transplantation. Again, the same slide which emphasizes all the target organ damage or end organ damage seen with hypertension. Now, retinopathy, this can be graded according to the Keith-Wagner classification, where it can be grade 1, where there is arteriolar thickening, tortuosity, increased reflectiveness, which is known as silver wiring of the blood vessels, can occur in grade 1. Grade 2 is when there is AV nipping, arteriovenous nipping, which occurs because constriction of veins at the arterial crossing can occur, because arterioles become thickened. Grade 3 is when there is renal ischemia, it can lead to exudates, flame shaped or hemorrhages or cotton wool exudates. Now, hemorrhages which occur in patients who have hypertensive retinopathy are flame shaped because they occur in the superficial layer called the rods, whereas in those which occur in diabetes occur in deeper tissue areas and called blot hemorrhages. Dot and blot appearance is basically seen in diabetic retinopathy, whereas in patients who have hypertensive retinopathy, the hemorrhages are typically flame shaped and it lead to also to cotton wool exudates. And in more grade 4 retinopathy is when it is associated with papilledema. That means there is edema of the optic disc. Now, this is again a picture of retinal picture which actually shows flame shaped hemorrhages, papilledema, hard exudates and cotton wool exudates. Spots are seen. Now, why should we treat hypertension? Because what are the evidence from trials or from clinical studies which have shown benefit on lowering blood pressure? When we control blood pressure in patients who have hypertension, it reduces the incidence of stroke by nearly 35 to 40%. Maximum impact is on reduction of stroke. It can reduce heart attacks by 20 to 25%, can reduce the incidence of heart failure by 50%, and also reduces all-cause mortality. So, there are tremendous benefits of controlling blood pressure and lowering the blood pressure to normal. And as we all know that there is a doubling of cardiovascular risk of developing a heart attacks or paralytic strokes for every 20 millimeters systolic and 10 millimeters diastolic blood pressure. As it increases, there is a doubling of risk of developing a heart attack or cardiovascular disease, which means that if a patient's blood pressure is 120 by 80 and his blood pressure becomes 140 by, that is 20 millimeters increase in systolic and diastolic from 80 to 90, that means so blood pressure of 140 by 90, the person has double the risk of developing a heart attack or a paralytic stroke as compared to a person whose blood pressure is 120 by 80. So on it goes on. So the relationship between cardiovascular morbidity and mortality with the blood pressure is linear, continuous, extends well below the cutoff level of 140 by 90 or 130 by 80. Meta-analysis of again has shown that just an average mean 2 millimeter decrease in systolic blood pressure in the community would lead to a dramatic decrease of 7% mortality due to ischemic heart disease and 10% decrease in mortality due to stroke. And therefore, one cannot overemphasize the importance of blood pressure control in reducing the risk for development of cardiovascular disease. What investigations we need to do? We need to investigate for target organ damage, ECG, very important. It will show whether the patient has left ventricular hypertrophy or whether there is diastolic or systolic dysfunction. And echocardiogram also is, the echocardiogram actually will tell you whether there is a systolic or diastolic dysfunction is present or not. We may do a treadmill testing to find out whether there is a late ischemic heart disease the patient has got, which gets manifest only on exertion. For kidneys, we have to do urine albumin creatinine ratio. We have to see for microalbuminuria or macroalbuminuria. We have to do for serum creatinine and blood urea, other tests. For retinopathy, fundus examination may have to be done, and for risk factors, we have to assess the body mass index, waist by hip ratio. We have to do the blood sugar, post fasting, post meal. Lipid profile has to be done, and ask the patient regarding the intake of fruits and vegetables, whether he smokes tobacco or uses smokeless tobacco in the form of chewing tobacco, and whether he consumes alcohol or not. These risk factors have to be assessed. So we have to assess for target organ damage, we have to assess for all the risk factors. And of course, we have to rule out secondary hypertension, because secondary hypertension is one hypertension which is totally curable, and if you remove the cause, the patient's blood pressure returns back to normal. And for that, we may have to investigate the patient for Cushing syndrome, for which we may have to do cortisol levels, and we may have to do for renal and renovascular hypertension, we may have to do renal ultrasound and renal Doppler angio, and we may have to do an investigate for primary hyperaldosteronism by viewing the plasma renin activity by aldosterone ratio, where the patients usually present with high blood pressure, hyponatremia and kalemia. Hypernatremia, in fact, hypokalemia with hypertension, one should always rule out primary hyperaldosteronism. Plasma and urinary catecholamines, cortisol can be done for pheochromocytoma, investigate for thyroid also when indicated. So, investigations for secondary hypertension would depend on whether there is any clinical clue to any disease which can cause hypertension. And also, it is very important to assess all other risk factors and do what is known as the cardiovascular risk assessment, and we have to calculate the risk of a person developing a heart attack or a paralytic stroke in another next 10 years. And there are various scores called the Framingham heart score. There is an inter-heart risk score which can actually predict what is the risk of a person who depending on the number of risk factors the patient has, we can calculate the risk of developing a heart attack or paralytic strokes in the next 10 years. And therefore, we patients who are at high risk, we have to categorize patients into low risk, moderate risk and high risk. For low risk, there is less than 10% chance of developing a heart attack in next 10 years. Moderate is between 10 to 20% and high risk is more than 20%. And we may have to categorize patients into mild, moderate and high risk patients. Patients who are at high risk, we have to be very aggressive in treating all the risk factors and also bringing down the blood pressure more aggressively and more rapidly to normal. That is very important to do that because that will help us in reducing the overall probability of developing a heart attack or a paralytic strokes. And we may have to use combination medications to bring down blood pressure, because it is very important that we bring down the blood pressure rapidly. And if the goal blood pressure is more than 20 by 10, that is more than 20 millimeters systolic and 10 millimeters of diastolic, we have to bring down the blood pressure to by using a combination of two medications in a single pill, or we may have to use triple combination medications also. So, what is very important is that we do not treat the figure of blood pressure, but we treat the patient as a whole by calculating the risk, and this is the risk of developing a heart attack or a paralytic stroke. For example, there is a Framingham risk scores which will take into account the age, the sex, the cholesterol, lipid profile, the smoking status, whether the patient has diabetes, the level of blood pressure, all these things will be collated, and we can categorize the patient into low risk, moderate or high risk patients. And patients who are in high risk needs to be treated very aggressively. So, what is very important to understand in the treatment of hypertension is that we do not have to treat the number, we have to treat the patient. Where say for example, if there is a blood patient whose blood pressure is 160 by 100, young patient about 45 years old, he is not a smoker, he is not obese and he does not have diabetes, and in this situation we are not very aggressive in bringing down the blood pressure, we give him a chance to bring down his own blood pressure by lifestyle modification. But if the same blood pressure of 160 by 100 in a 65-year-old person who is a diabetic, who is obese and is a smoker, the risk of developing a heart attack is very high in this patient. In that situation, we need to bring down the blood pressure this very rapidly and aggressively to reduce his risk and also take care of his other risk factors. So, the same blood pressure 160 by 100 would be treated differently in different patients, because we treat the patient and the patient's risk in order to prevent heart attacks and paralytic stroke. We do not treat the number. The number is important, but one of the components of the patient's whole risk, absolute risk of developing a heart attack or a paralytic stroke in the next 10 years. And that is very important that we assess for that by calculating this Framingham risk score or the inter-heart risk score. How much to treat hypertension? What should the goal blood pressure should be? Now the goal blood pressure should be less than 130 by 80, but in patients who have left ventricular failure dysfunction, the blood pressure goal may be still lower to 120 by 80. And when the goal blood pressure is more than 120 millimeters systolic and more than 10 millimeters diastolic, two or more drugs or combination medications have to be start right at the beginning. And there are very specific, like in patients who have left ventricular dysfunctions, we need to be 120/80. For other diseases, less than 130/80. Uncomplicated hypertension, one can be less aggressive. One should remember that the risk operates in continuum and not across arbitrary threshold. The relationship between hypertension and blood pressure and the cardiovascular risk is continuous, and the linear increases in a linear fashion as the blood pressure increases, and it extends well below the cutoff level of 130/80. And the Framingham data has clearly shown that the 50% of risk of developing a heart attack, which is attributable to high blood pressure, occurs in the range of blood pressure which is less than 140/90, which indicates that even blood pressure less than 140/90 is not, can cause heart attacks and paralytic strokes. So these cutoff levels are totally man-made, and therefore have to be taken, lower the blood pressure, better it is. There is a majority of heart attacks arise in population from the middle distribution of a risk factor, then it is high end. For example, if you want to, that is population wide risk, and coexistence of risk factors actually are interactive and multiplicative, and not synergistic action is there, and not only additive. Now look at these patients, two different scenarios. We have a patient whose serum cholesterol is marginally elevated, blood pressure is moderately elevated, mildly elevated 132, that is patient B, and he is a smoker. Whereas one patient whose one serum cholesterol is markedly elevated with a normal blood pressure and a non-smoker, you will be surprised that the risk of developing a heart attack is 5 times greater in patient B. So we should not be, we should be worried about mild elevations of multiple risk factors, and risk factors often cluster together, and most populations, the majority of heart attack events occur in individuals with modest elevations of multiple risk factors, then rather than marked elevation of a single risk factor. So that is something very important to understand when you want to prevent heart attacks and paralytic strokes. And hypertension is basically a symptomatic disease, a silent killer. And the only reason why we want to control hypertension and treat hypertension is to prevent heart attacks, and for remembering that we have to assess for other risk factors and and categorize the patient in low, moderate and high risk patients for developing a heart attack subsequently. So goals of antihypertensive therapy are to control, not only to control blood pressure, but to reduce mortality and morbidity due to complications of hypertension and reduce left ventricular hypertrophy, improve quality of life so that the patients have less side effects, and need to have 24-hour coverage. We know that there is a morning rise surge of blood pressure. Majority of heart attacks and paralytic strokes occur between 6 a.m. to 12 p.m. in the morning, because the blood pressure surges as a part of the circadian rhythm. The blood pressure is maximum in the morning hours, and that needs to be covered. And we also, is very important that cost is an important issue, because once a hypertensive, always a hypertensive, and therefore blood pressure medications have to be taken many times lifelong, and compliance has to be measured. Compliance has to be measured very importantly, because majority of patients do not take medications. This we can skip. What are the pharmacotherapy? What are the drugs available for treatment of hypertension? We have ACE inhibitors or ARBs, which are basically renin antagonists. We have two types of hypertensives. One is renin dependent, the other is salt sensitive. Some patients are very salt sensitive. If they take lot of salt, the blood pressure rises. Some patients are not salt sensitive, but have high renin activity. And therefore, there are two very important classifications where we have to target in the pathophysiology and treatment. One is anti-renin drugs which inhibit the renin angiotensin aldosterone system, are ACE inhibitors, angiotensin converting enzyme inhibitors, or angiotensin receptor blockers. The second group of drugs are calcium channel blockers like amlodipine, which is a dihydropyridine, nifedipine sustained release, and certain non-dihydropyridine drugs, calcium channel blockers like verapamil and diltiazem, but these are not usually used for the treatment of hypertension. The treatment for hypertension generally in calcium channel blockers we use amlodipine very commonly. It's a very good drug. It's a basic action of calcium channel blockers is that they cause vasodilatation and bring down the blood pressure and decrease the peripheral resistance. The important side effects of calcium channel blockers is that it can lead to constipation, and sometimes amlodipine is known to cause edema feet, which is actually reduced by another drug class of drugs called cilnidipine. Cilnidipine is also a calcium channel blocker, which is also renoprotective and will decrease the blood pressure, and with chances of developing the edema feet are less with cilnidipine. So, if the patient develops edema feet, we may have to switch over from amlodipine to cilnidipine in order, because they are very good antihypertensive agents. Some of them patients who are on antihypertensive agents can cause headache and tachycardia or some of the other side effects which can occur with calcium channel blockers. But amlodipine is one of the most commonly used antihypertensive agents. Beta blockers can be selective or non-selective. So, non-selective drugs like propranolol are not used in the treatment of hypertension because they have other side effects. But most commonly we use selective beta blockers like atenolol and metoprolol and bisoprolol. Some of the beta blockers which are very commonly used. Diuretics, which help in increasing the excretion of sodium, and we generally use mild diuretics like hydrochlorothiazide or chlorthalidone, which basically acts on the distal convoluted tubule, and they have a mild natriuretic natriuresis. Usually loop diuretics like furosemide or bumetanide are not used in the treatment of hypertension. They are used only when the hypertension is complicated by either congestive heart failure or patients of hypertension develop renal failure. In that situation, more potent natriuretic loop diuretics like furosemide or bumetanide are used. Another diuretics are potassium sparing diuretics or mineralocorticoid receptor antagonists like spironolactone and eplerenone can also be used in hypertension, and they are used in the later stages, especially if there is no response to these medications, initial medication, first line medications. Alpha adrenergic drugs blockers like prazosin is also used in the treatment of hypertension. Alpha and beta adrenergic blockers like labetalol or carvedilol. Now, labetalol is basically used in the treatment of hypertensive emergencies. It is given in the injectable form, 20 milligrams, can be repeated after 20 minutes, and it is also safe in pregnancy. So, alpha and beta adrenergic blockers like labetalol and carvedilol. Now, labetalol is used in hypertensive emergencies and hypertensive urgencies, where we want to bring down the blood pressure very rapidly. It is given in intravenous form, and 20 milligrams of labetalol is given, and which can be repeated after 20 minutes, so that it has a immediate rapid reduction in blood pressure. Carvedilol is also an alpha and beta adrenergic blocker, which is basically used in patients who have heart failure. There are certain centrally acting sympatholytic, they decrease the sympathetic flow from the brain. These drugs are alpha methyl dopa and clonidine. They decrease the sympathetic flow from the brain. There are certain other vasodilators, mainly arteriolar dilators like hydralazine and minoxidil. They cause dilatation of the arteries and therefore reduce the peripheral resistance. And there are drugs which act both on the arteries and veins and cause dilatation of arteriolar as well as venous dilatation like sodium nitroprusside. Now, sodium nitroprusside is again a drug which is used in hypertensive emergencies in the intravenous form, in the slow drip form. So, these are the various classifications of drugs which are used available in the market for antihypertensive medications. One should remember blood pressure is a product of cardiac output and peripheral resistance. What we can do is to reduce the cardiac output, and cardiac output we know is a product of preload, afterload and heart contractility and sodium and water retention. So, we can cardiac output is basically amount of blood which is pumped out every minute. Stroke volume is the amount of blood which is pumped out every minute, every beat, and stroke volume into heart rate is cardiac output. So, we can have drugs which can decrease the cardiac output or which can decrease the peripheral resistance, and a combination of these drugs may be useful in treatment of hypertension. Now, this is what I was talking about, the renin-angiotensin-A inhibitors and ARBs, angiotensin receptor blockers and angiotensin converting enzyme inhibitors. Angiotensin 1 is secreted, is formed by the conversion of angiotensinogen from the liver to angiotensin 1 by renin. Renin is a proteolytic enzyme which is secreted by the juxtaglomerular apparatus from the macula densa, and these cells, renin converts angiotensinogen to angiotensin 1, and angiotensin 1 is converted to angiotensin 2 by an angiotensin converting enzyme. And angiotensin 2 has got two important functions. One is that it is an important peripheral vasoconstrictor, and it also acts on the zona glomerulosa, which is the outer layer of the adrenal cortex, to produce aldosterone. Aldosterone is a very important substance, mineralocorticoid, which causes sodium and water retention, and that causes edema of feet, and it also increases the blood pressure. And therefore, we have drugs like angiotensin converting enzyme inhibitors, which inhibit the angiotensin conversion of angiotensin 1 to angiotensin 2, and then we have more peripherally acting RAS inhibitors. This whole thing, the picture which you are seeing, is known as the renin angiotensin aldosterone system, and we have angiotensin converting enzymes which works proximally to prevent the conversion of angiotensin 1 to angiotensin 2, whereas angiotensin receptor blockers actually act more peripherally and prevent the action of angiotensin 2 on these receptors. So then we have angiotensin converting, which counters the RAS activation. They reduce peripheral resistance, reduce afterload, and they also reduce salt and water retention by reducing aldosterone secretion, and therefore reduce preload. And also they have a long-term effect on the blood vessels, preventing remodeling, and may be responsible for the observed reduction in morbidity and mortality. These drugs are excellent drugs which are used not only in hypertension as the first line medication, but also they are used as the first line medication in patients who have heart failure, and also after heart attack they need to be started immediately, so that it helps in preventing the deleterious remodeling of the heart which occurs after transmural myocardial infarction. It is also important in diabetes mellitus and prevents the deterioration of GFR and the occurrence of nephropathy. The rate of progression of nephropathy in diabetes mellitus is decreased by these angiotensin converting enzyme inhibitors, and also by the RAS, by the angiotensin receptor blockers. The side effects of angiotensin converting enzyme inhibitors are because they can cause angioedema, absolutely contraindicated in bilateral renal artery stenosis, and those patients who have pregnancy or who have want to plan a pregnancy, there is a risk. In these patients, they should not be used. Angiotensin receptor blockers can be used where there is history of angioedema due to ACE inhibitors, and one of the important side effects of angiotensin inhibitors, ACE inhibitors, is basically it can cause chronic cough, and which is non-productive. In that situation, ARBs can be used. The side effects of angiotensin receptor inhibitors, angiotensin converting enzyme inhibitors, is that it can cause hypotension, that is systolic blood pressure less than 90 can occur. This is particularly more common in patients who develop in the first dose, because in patients who have already been hypertension, who have already been given diuretics, and their volume contracted, in that situation, if you give ACE inhibitors, their blood pressure is maintained by or increased because of activation of RAS, and in that situation, even a low first dose phenomenon, you give a small dose of ACE inhibitors, the blood pressure may drop precipitously, and therefore one should look for this first dose phenomenon in patients who are volume contracted. In that situation, and subsequently the patients may in fact tolerate very large doses of ACE inhibitors, but the first dose is therefore very important to prevent hypotension in some patients who are volume contracted. Because if they have received diuretics, it is possible that they are volume contracted, and in that situation, if you give ACE inhibitors, it might cause a precipitous drop of blood pressure, which may not occur subsequently with even higher doses. Hyperkalemia is also one of the side effects of ACE inhibitors, and especially if they are combined with potassium sparing diuretics or mineralocorticoid receptor antagonists like eplerenone and spironolactone, and if the patient has got chronic renal failure, in that situation, chronic kidney disease, in that situation, chances of developing dangerous hyperkalemia is common. Has to be looked carefully, because that can be deleterious. Patients may have non-productive. We have seen about 5 to 10% of patients who have put on ACE inhibitors. This is a side effect, angioedema and non-productive cough. These are two side effects which are very peculiar to ACE inhibitors, not seen with ARBs, and therefore patients who have ACE inhibitors who develop angioedema or who develop chronic non-productive cough, which is many times distressing for the patient can be shifted to angiotensin receptor blockers, which do not cause angioedema and do not cause cough. So, non-productive cough, one should remember that is a peculiarity which is seen with ACE inhibitors, and we should always see that in a patient who presents with chronic cough, whether the patient is on ACE inhibitors. Otherwise, I have seen patients who have been investigated for chronic cough, including a bronchoscopy, but have not taken history properly. This and simple stoppage of ACE inhibitors and would stop this non-productive cough. Angioedema and skin rash peculiar to ACE inhibitors. If that develops, the patient needs to be shifted on angiotensin receptor blockers. And if the patient has chronic renal failure, one should really be careful about hyperkalemia. And these drugs, therefore, as I have told, to prevent first dose hypotension, one needs to be starting with low doses. I used generally enalapril and ramipril. Lisinopril also can be used. Ramipril, for example, can be started with 1.25 milligrams once a day and can be built up to a dose of 10 milligrams. Enalapril can be started in BID doses 2.5 milligrams to 10 to 20 milligrams twice a day it can go. Angiotensin receptor blockers are therefore indicated, are more slightly expensive more as compared to ACE inhibitors. They are used in patients who are intolerant to ACE inhibitors or are contraindicated, but side effects are very similar to ACE inhibitors, except that it does not cause chronic cough and it does not cause angioedema. The two most commonly used angiotensin receptor blockers are telmisartan 40 to 80 milligrams once a day, or olmesartan 20 to 40 milligrams once a day. Thiazide-like diuretics, very commonly used many times. We generally use only hydrochlorothiazide or chlorthalidone. The advantage of chlorthalidone, it is a more longer half-life, and therefore once a day dose is sufficient, and it is now the standard to use chlorthalidone rather than hydrochlorothiazide, but because of its lesser side effect profile. They are mild diuretic, they act on the DCT, and therefore are useful in patients who have hypertension, but more loop diuretics, stronger loop diuretics are used only in patients who develop heart failure or renal failure. There are drugs like potassium sparing diuretics like amiloride or mineralocorticoid receptor antagonist, which can be combined with loop diuretics or with hydrochlorothiazide in patients who have uncontrolled or refractory hypertension to control the blood pressure. It's important to remember that these thiazide-like diuretics or loop diuretics can cause electrolyte imbalance. They can also cause hyperuricemia and can precipitate gout and cause dysglycemia and cause unmasked diabetes mellitus. So, reducing blood pressure is important because 80% of hypertensive in the community have uncontrolled blood pressure, and how it is controlled is also important. We need to use drugs judiciously, and there are certain side effects of diuretics. They can cause hyponatremia, hypokalemia, metabolic alkalosis, and cause azotemia, prerenal azotemia, volume depletion. It can unmask diabetes, hyperglycemia and hyperuricemia and hyperlipidemia are some of the side effects, and ototoxicity sometimes. Beta blockers could be selective or non-selective, and we use usually selective beta blockers like metoprolol is most commonly used in the treatment of hypertension, not as first line drugs, but as second or third line drugs. And given the doses, either controlled release or sustained release preparations of metoprolol are available, we start from 12.5 to 25 milligrams once a day. We can increase this up to 200 milligrams once a day. That is usual maximum dose. Bisoprolol also 1.25 milligrams to 10 milligrams once a day can be given. Carvedilol is a non-selective beta blocker which also has alpha-1 blocking action, therefore a very useful drug in the treatment of heart failure, but it's rarely used in the treatment of hypertension. Some of the side effects of beta blockers are they have a negative inotropic and negative chronotropic action, and because of this they decreases the cardiac output, and also because they can cause generalized fatigue and weakness, and they cause bradycardia, and patients who have heart blocks can be exacerbated. It can lead to a fall of blood pressure, it can cause bronchospasm, and therefore patients who have bronchial asthma should be used, the beta blocker should be used with caution, and they can also cause an unfavorable profile effects on the lipids. They can cause also in patients who are diabetics, one should be careful because the symptoms of hypoglycemia can be masked by patients who are beta blockers. What happens when there is hypoglycemia, when the blood sugar falls, is that there is activation of sympathetic activity, and the patient starts sweating and there is tachycardia. This will not occur in patients on beta blockers. Therefore, important warning signs of hypoglycemia may be masked in patients who are on beta blockers, and therefore this point should be noted and important should be understood, and when we are treating patients who have hypoglycemia who are on beta blockers. So, initiating treatment, we can offer antihypertensive treatment by starting one drug or have who under the age of 80 years with stage 1 who have one of the following. If the patient has target organ damage and has got a cardiovascular risk of developing a heart attack of within 10 of moderate to high risk, they should be immediately treated and blood pressure should be started. In stage 2, there is no question, blood pressure should be brought down to normal immediately. And the combination therapy is recommended if blood pressure is more than 20/10 of goal blood pressure. Now, there are very compelling indications which drug to be used. For example, if a patient has heart failure, the drug of choice should be either an ACE inhibitor or ARBs along with a diuretic, because these are, and beta blockers, because these are drugs which are as such used in the treatment of heart failure. Similarly, after a heart attack, it has been shown that ACE inhibitors and ARBs actually prevent ventricular remodeling and improve survival, and should therefore always be used in the treatment. And beta blockers also have been shown to improve survival after heart attacks, and they should also be used in patients who have already suffered a heart attack. Patients who are diabetics, we should definitely be using ACE inhibitors, because we have told you that in diabetics, they slows the decline of GFR and delays the onset of diabetic nephropathy in ACE inhibitors and ARBs in patients who have diabetes. Therefore, very important. So, there are very specific compelling indications where specific drug have to be used which are useful. Beta blockers, for example, are used in the treatment of heart attacks, after coronary risk, and patients in heart failure, and especially younger patients where there is a lot of hypersympathetic activity, the heart rate is increased, sympathetic activity is high. In that situation also we can, when the pulse rate is more, in that situation beta blockers would be useful. Calcium channel blockers are particularly useful in elderly people. They bring down the blood pressure rapidly. In elderly, calcium channel blockers along with diuretics work very nicely in bringing down the blood pressure. ACE inhibitors work better in patients who are diabetics, who have nephropathy especially, and patients who have heart attack or heart failure. And this is the British Hypertension Society guidelines for patients less than 55 years and patients more than 55 years. In patients, step 1 is that we use either ACE inhibitors or ARBs in patients less than 55. After the age of 55 years, it's better to use amlodipine or calcium channel blocker. If the blood pressure is not controlled, then we can combine ACE inhibitors and calcium channel blockers, and we can, the third step, we can combine all the three, that is ACE inhibitors, calcium channel blockers, and diuretics can be added. And for resistant, we can consider alpha blockers or alpha beta blockers, and also we can use a mineralocorticoid receptor inhibitor. So this is the stepwise approach of in patients. Similarly, this is the latest British Hypertension Society guidelines. They have again classified the use of ACE inhibitors, ARBs in patients less than 55, calcium channel blockers in more than 55, and then to combine these three drugs in patients who have hypertension. So, monitoring blood pressure, that we need to take blood pressure in sitting, also in blood pressure in the standing position to rule out postural hypotension, especially in patients who are elderly or in patients who are on who are diabetic, or even drugs like alpha blockers. Alpha blockers like prazosin is particularly useful in patients who have benign hypertrophy of prostate, and it has been shown to improve the urine flow in patients who have because it relaxes the urinary muscles, sphincter muscles, and therefore it helps in improving the symptoms of benign hypertrophy of prostate in patients, and therefore alpha blockers like prazosin, which is available in sustained release preparations like 2.5 or 5 milligrams once a day, can be given in patients who are elderly and who also have benign hypertrophy of prostate. The drug of choice there would be prazosin, which is an alpha blocker. Beta blockers are not preferred initial medications, and because it causes hyperglycemia, and ACE inhibitors and calcium channel blockers are better than third line of drugs we can as beta blockers. Usually we should not combine beta blockers and a diuretic, because both of them can cause hyperglycemia and can unmask hypertension, especially in those patients who have metabolic syndrome. Role of diuretics is much less than what it was there previously, and they are in the step 3. In the step 4, we have to add a alpha blocker, or we can add a mineralocorticoid receptor blocker. That means low dose spironolactone works wonderfully if in patients who have resistant hypertension. And resistant hypertension by definition is hypertension which remains uncontrolled. Goal hypertension, blood pressure is not achieved by 3 drugs used in optimal doses, one of which is a diuretic. So there are this is a very clear definition, and where compliance of the patient has been we have to assure that the patient is taking medications. So if the patient's goal blood pressure is not achieved by 3 medications used in optimal doses, one of which is a diuretic, and goal blood pressure is not achieved, that is called resistant hypertension. Rule out non-compliance with therapy, which is very common in hypertension. So these are some of the pearls lessons that we have to measure office blood pressure at appropriate technique, and we have to use also ambulatory blood pressure or home blood pressure monitoring to rule out masked hypertension and office white coat hypertension or vice hypertension. We can use a low dose fixed combination to improve compliance, because it will provide additional antihypertensive efficacy and will minimize dose dependent side effects. Once a day it can be administered, cost is reduced and compliance is improved. So combination drugs are definitely useful because it will improve compliance and it will decrease cost. Number of pills burden would definitely decrease, and we should usually combine 2 drugs which have different mechanism of action, act at the different pathophysiology. So there are basically 2 types of hypertension. One is the high renin hypertension, which is low volume, and the other is low renin, which is salt sensitive. So in patients who have high renin hypertension, we can use ACE inhibitors, ARBs. Patients who have salt sensitive, beta blockers would be, or this diuretics, thiazide diuretics work better, and combination would therefore useful in countering both the types of pathophysiological mechanisms for increase in blood pressure. So combination therapies are now used very commonly to improve compliance, to decrease cost, and to bring down the blood pressure more effectively. For diabetes mellitus, this is again class of recommendation and level of evidence. Class 1 indication, one is that when patients blood pressure should be brought down to 130/80, and the first line of drugs is ACE inhibitors or ARBs, and they can be combined with calcium channel blockers. For stable ischemic heart disease, we may like angina, we may have to use ACE inhibitors along with beta blockers. And patients with reduced ejection fraction, we have to use these ACE inhibitors again, but we should be careful that we should avoid drugs which have negative inotropic action, like non-dihydropyridine calcium channel blockers, verapamil, are contraindicated in patients with heart failure with reduced ejection fraction. For preserved ejection fraction, diuretics are useful, and also sodium glucose co-transporter inhibitors, 2 inhibitors are useful in patients who have heart failure with preserved ejection fraction. We can, in pregnancy, which drugs have to be used is very important. That drug we do not have any counter people who are planning pregnancy also. In that situation, certain drugs are contraindicated. We cannot use ACE inhibitors or ARBs in females in the reproductive age group and who are planning pregnancy. The drug of choice in pregnancy induced hypertension, that means hypertension which is detected during pregnancy. The safest drug is alpha methyl dopa, 500 milligrams twice a day, can go up to 2 grams per day. Or the another drug which is labetalol or nifedipine. These are other drugs which can be used very safely in pregnancy. Amlodipine that means calcium channel blockers, also can be used in pregnancy without much side effects. Beta blockers and ACE inhibitors, ARBs should be avoided totally. So women with hypertension who become pregnant should not be treated with ACE inhibitors and ARBs or direct renin inhibitors. So resistant hypertension, I have already told you, when the office blood pressure remains more than 130/80 with 3 drugs, one of which is a diuretic used in optimal doses despite use of 3 medications. If the blood pressure continues to be elevated more than 130/80, that indicates that the patient has resistant hypertension. We have to do specific investigations to rule out secondary hypertension, and further specialist referral is needed here. So I think we can skip this. Cognitive decline, blood pressure lowering is reasonable to prevent cognitive diminution. Now I will come to very important non-pharmacological interventions for treatment of hypertension. Weight reduction can reduce blood pressure by nearly 5 to 20 millimeters of mercury. We have to adapt a DASH eating pattern. What is DASH? Is dietary approaches to stop hypertension, which consists of taking fruits and vegetables, about half a kilo of fruits and vegetables per day, decrease in dairy food, and also decrease in salt intake is what is known as DASH eating pattern, which can reduce blood pressure by systolic blood pressure by nearly 8 to 14 millimeters of mercury. Dietary sodium restriction itself will reduce blood pressure to less than 2 to 8 milligram. Physical activity will reduce blood pressure by 4 to 9 millimeters, and moderation of alcohol intake will reduce blood pressure. Alcohol is important because alcohol causes pressor effect and may increase blood pressure. So limiting alcohol intake will also help in reducing the blood pressure. So emphasis on accurate measurement of blood pressure is important. We have measurement of blood pressure should be done by a standardized method. We have to use liberal use of what is known as ambulatory blood pressure monitoring or home blood pressure monitoring, and revise and aggressive treatment goals of blood pressure being less than 130/80 should be the target blood pressure. We should use risk assessment of our cardiovascular risk scores, that is the Framingham risk score, to assess whether the person belongs to low, moderate or high risk group. And lifestyle modifications should be emphasized. We have to start with ACE inhibitors, calcium channel blockers or ARBs, or diuretics, and chlorthalidone is now the preferred diuretic. Upfront use of combination therapy, especially in patients who have stage 2 hypertension, is important. One important point is hypertension in the elderly. All patients who are elderly blood pressure should be brought down. Systolic blood pressure is more important predictor after the age of 50 years. We should start slowly and go with low doses initially. So go slow and low is important. Goal blood pressure should be less than 140/90. We should be worried about postural hypotension, and therefore we need to take the blood pressure in recumbent as well as in standing position, because many of the elderly patients, they have autonomic dysfunction and may develop postural hypotension, which may be very distressing to an elderly patient. How intensively we need to bring down the blood pressure? We need down to bring the cutoff levels are the same, and we may have to increase, and systolic blood pressure is very common with a normal isolated systolic blood pressure. Diastolic blood pressure may be normal in elderly, and it's very difficult. We have seen patients who have systolic blood pressure 170, 180 and a diastolic blood pressure of 70 or 80. This is quite common in elderly patients, and in that situation we have to bring down the systolic blood pressure so that we prevent heart attacks and paralytic strokes in these patients. And we have to be worried, and the diastolic blood pressure up to 70 millimeters is okay. Below that we have to maintain the diastolic blood pressure at 70 millimeters, and see that the systolic blood pressure is brought down as much as possible in elderly. So choosing an hypertensive, we can, in elderly patients, it has been seen that calcium channel blockers and diuretics are the drugs which of choice, and because they have isolated systolic hypertension, and the lifestyle modifications like intake of fresh fruits and vegetables, which are a rich source of potassium, antioxidant vitamins like vitamin C, A and folic acid, fiber, and are very important because they decrease the homocysteine. And we have to there are a lot of advantages of exercise. Therefore, excess walk should be graded according to the age of the person, and about at least 50 minutes of brisk walking every day should be advocated. In younger patients, we can ask them to jog, and we may have to calculate what is known as the target heart rate, which is 220 minus age in years and plus minus 15. That should be achieved in you do a more vigorous exercise. There are a lot of advantages of exercise, and psychosocial stress, I've already told, this can be reduced by doing relaxation, meditation, yoga, and negative biofeedback mechanisms. Rule of 5 is something which I will just finish off as. The WHO recommends that the average adult should not consume more than 500 grams of fat per person per month. This includes all forms of fat and oil, ghee, butter, everything. And each person should not consume more than 5 grams of salt per day. You can see we eat a lot of oil which is unnecessary, not physiologically required, and we also eat a lot of salt which is not physiologically required. We have to consume at least 400 to 500 grams of fruits every day and 500 grams of vegetables per day, and average consumption of fruits per day by an average Indian is about 130 grams per day, which is much less than the minimum requirement which is recommended by the WHO. We have to indulge in physical activity at least 50 minutes 5 times a week each, and we have to have so this is the rule of hypertension. I think we can skip these combinations, and hypertensive emergencies and other things we can discuss in the next class. Thank you very much for a very patient listening. Thank you very much.